Welcome to this Medscape Live event. Once this program begins, you will have access to several interactive features designed to enhance your educational experience. These include viewing the presentation slides, reviewing the agenda, and participating in live polling throughout the session. During the presentation, you can take notes if you are using the Medscape Live app. Your notes will remain available in the app after the event for future reference. Questions may be submitted to the faculty at any time, and selected questions will be addressed with responses provided during the Q&A portion of the program. At the conclusion of the event, educational credit can be claimed by clicking the Earn Credit link on the side panel or scanning the QR code. Presentation slides will be available for download immediately after the session using the Medscape Live app or by logging into your account at medscapelive.com. While you're on the Medscape Live app, you can explore and register for upcoming events. Thank you again for joining us. Our program will begin shortly.
Well, greetings and welcome to this program. Thank you very much for joining us for this session on hypercortisolism from diagnosis to long-term control. We look forward to having a great discussion with you tonight. There are some complex cases that we will discuss, diagnostic and management challenges, and then obviously look forward to your questions and have a discussion towards the end as well. Before we start with the program, a few quick housekeeping comments. On the right, you will see the internet connectivity information, so please do connect. The password is there as well. Because once you connect to the internet, then you can use that QR code so that you can communicate with us as well. You can use the same QR code and the link for slides and other material and content from this program, but more importantly, ask us questions and participate in polling questions. There are several polling questions during this program as well. The QR code should be there on your tables as well if you missed it on the screen. So we are all excited here to be with you. I am Dr. Javed Butler. I'm a cardiologist and a clinical trialist with Baylor Scott & White Health in Dallas, Texas, and professor of medicine at University of Mississippi. Together with me are two colleagues with deep expertise in the area of cortisol and related disorders, Dr. Irina Bancos from Mayo Clinic, endocrinologist, and Dr. Divya Yogi Moran from Cleveland Clinic, also an endocrinologist. Here is our agenda for today. Both the presentations are related to complex cases and management and diagnostic related issues. So first, Dr. Bancos will manage her case and discuss Cushing syndrome, and then Dr. Yogi Moran will discuss her case as well. Following that, I will give a short presentation and perhaps answer some of your questions as to why is a cardiologist sitting on the podium here for a cortisol talk. So we'll discuss a little bit about multi-specialty management and also the growing interest in this field within the cardiovascular community as well, and all the things that we need to learn. Following that, we will have a Q&A session. So again, we really want it to be interactive, so please do send in your questions for us as well. So with that short introduction, I will turn it over to Dr. Bancos for her first case challenge, Cushing syndrome, the initial management hurdle.
Thank you, Dr. Butler, and welcome everyone. So I will start with a case presentation. We'll call her Maria. She's a 49-year-old woman, presented initially to her local endocrinologist with an incidentally discovered bilateral adrenal adenoma phenotype. And this is what happened after that initial discovery in 2021. So appropriately so, she had a dexamethasone suppression test at the discovery of incidentalomas, and it was normal at 1.77 microns per deciliter. Then she had a repeat dexamethasone suppression test in 2023, and another one in later 2023 because it was abnormal, and yet another one also abnormal in early 2024. So you see some progression from 2021 to 2023, and it's persistent abnormality. I do want to show you how her adrenal nodules looked at initial presentation. So again, this is 2021. She had bilateral adrenal lesions, sort of elongated tumors, but clearly benign and lipid-rich. I actually measured Hansfeld units there for you, and it's between -12 to -5, depending on where you measure. The right adrenal nodule measured 3.7 by 1 by 1.7 centimeters, and the left 4.1 by 2.1 by 2.2 centimeters. It did not quite look like a macronodular phenotype on this image. So now it is 2024. Now she's 52. And now she does have some symptoms: chronic insomnia, fatigue, just not feeling well, to quote her. She also gained 10 pounds each year for a couple years, despite trying to work hard on her exercise and diet and so on. On physical exam, she does have mild supraclavicular fullness, central obesity. Her BMI is 29.5. She has several bruises over forearms. She reports easy bruising. As far as comorbidities, she has dyslipidemia, prediabetes, and osteopenia. And her hemoglobin A1C was available. It was 6.5% on no medical therapy. Okay, well, let's look at her hormonal workup. And this is her hormonal workup at that evaluation in 2024. Her baseline cortisol was 16 microns per deciliter. Her HDH was on the lower side of normal, but not suppressed at 9 picograms per milliliter. Her DHA sulfate was also on the lower side of normal, but not suppressed. And as I previously shown, her dexamethasone suppression test varied between 2.4 and 2.6 in the last couple of evaluations. So let's apply clinical severity score to this particular patient. And I'm going to use a clinical severity score we've been using for the last 7 years or so in our multiple publications as a part of PROMISE study. We have assigned a point or several point system to metabolic abnormalities and physical exam features, which was a bit of an expansion from what the field was saying to do at that time in 2019, to basically concentrate on these overt features of hypercortisolism. We decided to add comorbidities to that, mainly to include MACs, because the definition of mild autonomous cortisol secretion is having no overt features of hypercortisolism, at least not the ones that are easily recognized. But obviously, we know that mild autonomous cortisol secretion comes with a lot of cardiovascular factors. Now, if you look at the points, the more specific a particular feature is to hypercortisolism, the higher is the number that this clinical severity score gets. For example, for proximal myopathy is a maximum of 4. For DVT or PE, pulmonary embolus, it's maximum of 3. But central obesity, that is very common, or hypertension, that is very common, that gets only a point of 1. So I'm presenting this because I think it matters to understand patients' clinical severity at the time of evaluation to advise and counsel on the impact of treatment. As long as we're talking about severity, it's also important to talk about biochemical severity. And here's why. Biochemical severity is just a number that a person presents with. And usually that is not progressive. For example, in patients with autonomous cortisol secretion, we may have the dexamethasone suppression test to be 2.9 for decades, and no one does anything about it. But the clinical severity is a sum of how severe is biochemical hypercortisolism and how long a person has it without treatment. So it's doing both biochemical and clinical severity score that I think is most useful in the clinic. So I'm presenting to you our biochemical severity score for a stage-independent hypercortisolism because our patient has adrenal hypercortisolism. And this was based on, or should be based on, 2 most abnormal tests, because not everyone has all of these tests done in clinical practice. Okay, so let's review endogenous Cushing syndrome in general. Most Cushing syndromes that we see in the world, in the clinic, is Cushing disease, or pituitary Cushing syndrome, up to 72% based on several publications. Ectopic age-stage syndrome is very rare, 6 to 16% of all Cushing's cases. I would say 16% is probably more in referral centers. 6% is more if you just look at overall prevalence. And adrenal hypercortisolism is 20 to 30% of Cushing's cases. So now it's a time for a bit of engagement of the audience, and I hope you have your phones ready. I would be very interested to see how would you manage this patient in this stage. And just a reminder before you start answering, this is a patient with abnormal dexamethasone suppression test that is persistent, now has some features of overt hypercortisolism, clearly has some evidence of age-stage independent hypercortisolism, and is not feeling well. Has bilateral nodules as well, so that may make it a bit more challenging to decide the next step. Would you continue surveillance? Would you repeat biochemical testing? Would you start medical therapy? Would you evaluate by an adrenal surgeon? Or would you do additional localization studies? Okay. Well, I'm always curious to see how people feel about things, especially in the field where we all choose different things. So let's review. So only 3% want to do nothing. And I think this particular patient will be quite thankful for that, because she came for a second opinion because she was not comfortable doing nothing. 13% want to repeat biochemical testing, or I'm guessing maybe consider additional testing. 40% are ready for medical treatment. 22% surgical evaluation, additional localization studies, 22%. Now, I wish we had some, interactive element for you to tell me what localization studies you would do, because there's not much out there, at least in the United States. But really, majority wants to do something. So let's review the dilemma a little bit. Oh, I think I missed something here. Just a minute. Here. So I would like to review the management of autonomous cortisol secretion. And here I'm combining MACs, mild autonomous cortisol secretion, with overt adrenal Cushing's. Mainly because really the approach is similar, and because a lot of patients with MACs and mild adrenal Cushing sort of overlap, making it difficult to distinguish even for someone who sees a lot of these patients. So based on the imaging phenotype, we can consider different things. I would say the easiest decision-making would be for a person with unilateral adrenal adenoma and age-stage independent hypercortisolism. Because in this case, we know that there is only one single source of that autonomous cortisol production, and at least surgery would be curative in this case, should the patient decide for surgery. In that case, with surgery, we need to still be concerned about adrenal insufficiency and withdrawal that we will talk about later on, but at least the management is not as gray. It's a bit more black and white. Then if we have a person with macronodular adrenal hyperplasia, which in this picture, you see a nice example of that. Multiple conglomerated nodules, really massive adrenal glands, and it's very difficult to say that it's one single adenoma on the right and left. This is actually a picture from a patient of mine with RMC5 mutation. In this case, we know for sure that it is bilateral hypercortisolism. So now we just need to decide what do we want to do about it. Unilateral adrenalectomy, subtotal bilateral adrenalectomy, bilateral adrenalectomy, medical therapy, and no localization studies are needed because we already know that it's bilateral. Now, what I'm struggling with is what to do when a patient has bilateral adenomas. A nice example of a patient of mine in the middle, where you have only one single nodule on the left, one single nodule on the right, sometimes atrophic tissue around it. And the hope is that one of these nodules is actually non-functioning, and only one of them is cortisol producing. And as you may appreciate, in this particular case, the nodules are quite similar in size. So it's kind of 50-50, right? What if it's left non-functioning? You really do need something else here. So this is a rare population of patients with bilateral nodules that actually would benefit from adrenal vein sampling. So in this case, I would do adrenal vein sampling, or I would do adrenal vein sampling, which is a localization study I would choose, where in people where I'm not sure. Is it bilateral macronodular hyperplasia? Is it bilateral adenoma? Because it's not very clear to me based on the imaging. Why adrenal vein sampling? Well, if a patient wants surgery and adrenal sampling has a chance to show unilateral disease, it would guide the site of the surgery. So localization of dominant cortisol production. Importantly, it is not recommended for unilateral disease, only for bilateral adrenal adenomas. It's not recommended for micro or macronodular disease because it's always bilateral. And there's a typo. One of them should be macronodular. So this patient did have adrenal vein sampling. I would say her imaging phenotype was not completely convincing for bilateral adenomas, but I also was not convinced it was macronodular disease. So we did do AVS and the dexamethasone suppression. Why? Because dexamethasone suppresses any endogenous ACTH that is possible for that person to produce. And remember, high stage was 9, not completely suppressed. So that minimizes physiological cortisol fluctuation and helps us truly measure autonomous cortisol production and not ACTH-driven cortisol production. These are her results. Her IVC cortisol was 3.9, which was obviously above 1.8 after 6 milligrams of dexamethasone, so clearly abnormal. But as you see, her left and right adrenal veins were both in the range of a site that is producing cortisol. By the way, I'm not showing you the catecholamines, but it was successful cannulation in both sides. And unfortunately for her, showing bilateral disease. As you probably recall, we're not able to correct for dilution when we do adrenal vein sampling. So really, the decision here, is it unilateral or bilateral? And if it is bilateral, it's very difficult to trust AVS, which one produces more. Like with primary aldosterons, when we do AVS, it actually helps us to understand the gradient because we can correct for dilution, but not with current knowledge and current procedures of AVS for hypercortisolism. But we have our answer. We wanted to understand whether it's unilateral, and it is not unilateral. It is bilateral disease. I spent a little bit more time here because I know very few centers do adrenal vein sampling. Okay, so now she has follow-up CT scan in 2023. Or at least we had available that CT scan. It did change a little bit since 2021, but it still shows that it's bilateral adrenal disease. And depending on how you measure it, you will get sort of like this longish adrenal nodule. But it is very clear that the left side is bigger than the right. I'm showing you the most representative image, but if you go dynamically through the CT scan, I would say it's predominantly left disease. So we have asymmetric tumor bulk on CT scan in a person with an ACTH-independent hypercortisolism who wants management. And we have AVS telling us it's not unilateral disease. What would you recommend next for Maria? Do nothing, bilateral adrenalectomy, because, adrenal vein sampling was bilateral. Right adrenalectomy, medical therapy, or left adrenalectomy. Okay, so it seems like more people want to start medical therapy, 40% before, now it's 43. And we have sort of a division of decisions between right and left adrenalectomy. I am guessing those who chose left adrenalectomy probably were driven by the fact that left adrenal mass definitely looks larger than the right. And those who chose right adrenalectomy probably remember that AVS showed higher cortisol on the right than left. But remember, we cannot trust the concentration or dilution level. So depending on how concentrated that sample, it actually could have been quite reversed. 22% ready. Sorry, I'm not completely done with that. But 22% were ready for bilateral adrenalectomy. Now, we did do left adrenalectomy for her because we knew it was bilateral disease, and we were hoping that, consistent with evidence to date, larger tumor bulk in someone like that would also be associated with larger cortisol production. So despite the fact that adrenal vein sampling showed slightly lower cortisol on the left and right, we chose left adrenalectomy. Pathology was consistent with adrenal cortical adenoma. And how many of you think that she developed adrenal insufficiency after adrenalectomy? Maybe we can have show of hands. Okay, several. I would say it was quite possible. And I'll show you what happened. How many of you think, yeah?
Would the fact that the ACTH level was so measurable, does that help you decide?
That's a great question. I may have a slide on that, but let me tell you, if I don't, I'll answer this question. In our multi-center study on unilateral adrenalectomy in MAX, where they usually don't have suppressed ACTH levels, preoperative ACTH was not a good predictor of adrenal insufficiency. So I'm explaining it by the fact that ACTH, number one, is not a great assay. Number two, how much is enough to maintain trophy? How much is not enough to lead to adrenal atrophy? We don't know. And also, we don't know for how long this patient did not see enough ACTH. So maybe that's why measurement of ACTH, in at least measurable ACTH, is not a good predictor. Now, if ACTH is undetectable, it's pretty good predictor that a person will have adrenal insufficiency. But if it is not undetectable, you don't really know. I hope it's making sense. So, okay. How many of you think that we solved her autonomous cortisol production and her dexamethasone suppression test will be now normal? So I'll tell you what happened, but here's my approach to this. In general, I look at the preoperative dexamethasone suppression test, and let's say it was 2.6 in this person. And then I'm thinking, well, how much of abnormal tissue are we removing with unilateral adrenalectomy? If it is 60%, then dexamethasone suppression test is very likely to decrease by 60%. And that actually could get it into the normal range. Humans are not always following the math, but overall, as a group, it's a pretty good predictor. Maybe not on an individual level. So I would say she could normalize her dexamethasone suppression test, and I'm not sure she would develop adrenal insufficiency. Now, it's a bit unfair because I know what happened. So if I can actually move the slide, for some reason it doesn't work.
Can I try this one?
Okay. Oh, and now it moved too much. Okay. So I'm going to show you first some data on recovery of adrenal insufficiency after remission for hypercortisolism. So if a person develops adrenal insufficiency, let's say after this unilateral adrenalectomy, in mild hypercortisolism, the median amount or duration of adrenal insufficiency would be around 4 months. And it does depend on the baseline clinical and biochemical severity. If you have mild clinical and biochemical severity, adrenal insufficiency would be of short duration. If it is moderate or severe, it's more like a year. So this is her data. She actually did not develop adrenal insufficiency. Her baseline cortisol was 12, and actually in someone with bilateral hypercortisolism, the peak cortisol is almost always normal. So let's say her baseline cortisol is 3 microns per deciliter, not 12, and peak cortisol is 22. I would not have been reassured that she does not have adrenal insufficiency, because remember, all that abnormal tissue would respond to casintropin. So this is the pearl. If you're doing casintropin stim test after unilateral adrenalectomy for bilateral disease, don't trust your peak post-casintropin level. Look at the baseline. But as a part of our protocol, people do get casintropin stim tests, so I have this data. But baseline cortisol is not low. So I'm pretty reassured that she did not develop adrenal insufficiency. So she was discharged on no glucocorticoids. She did develop mild glucocorticoid withdrawal syndrome despite the fact that she did not develop adrenal insufficiency. Symptoms improved, though, over the next 3 to 4 months. And that's when we repeated dexamethasone suppression test. And as you see, it normalized. I mean, we can argue whether 1.5 is normal or not, but it is under the cutoff of 1.8, which is considered abnormal. So did we fix her? I mean, I'm still worried about her future risk of recurrent hypercortisolism because clearly she already showed that it was progressive. And unfortunately, this is what happened. And this is when I'm seeing Maria the second time in 2026. Now her urine cortisol is just above normal range. Her ACTH now is 7 picograms per milliliter. Now our reference range is 6 to 60, so almost undetectable. And now her DHA sulfate is lower than before. Her cortisol after 1 milligram dexamethasone is 2.7 microns per deciliter. And her cortisol after 8 milligram dexamethasone is 2.1, which is similar to 1 milligram dexamethasone suppression test, which is usually the case. In adrenal hypercortisolism, cortisol after 1 and 8 milligram dexamethasone are usually in the same range. And this is how her CT is looking. Obviously, she has no left adrenal gland because she had adrenalectomy. And her remaining adrenal gland on the right actually grew a little bit. I actually don't have the report here, but it grew by around 1 centimeter, explaining why she now has recurrent hypercortisolism. So what would you recommend next for Maria? Now she has only 1 single adrenal gland. She bought herself a couple years of no hypercortisolism, no adrenal insufficiency, but now she has hypercortisolism again. Would you say this is it? Just keep up with it? Medical therapy now, contralateral total adrenalectomy, or subtotal partial adrenalectomy, if you have a good surgeon. Okay. With each question, more and more people vote for medical therapy. I actually discussed with her all of the 3 options. I mean, observation usually is not something that people come to me to talk about. So I discussed with her different options for medical therapy, contralateral total adrenalectomy, and contralateral subtotal adrenalectomy. And after listening to all of this, I guess, okay. I guess I'm not going to tell you what she decided yet. First, I'm going to tell you pros and cons. So if she did decide contralateral adrenalectomy, well, the pros are the definitive biochemical control, because you know how many times every couple of years someone can come back with recurrent hypercortisolism and all the symptoms. But the cons is a lifelong adrenal insufficiency. Not everyone does well with adrenal insufficiency, though certainly our experience at Mayo Clinic is better than what I hear around the world. But still, maybe 5% or so of people with primary adrenal insufficiency regret having bilateral adrenalectomy. And obviously, there is always adrenal crisis risk. So medical therapy, steroidogenesis inhibitors or glucocorticoid receptor antagonists is something that would work in adrenal hypercortisolism. Pros is avoiding permanent adrenal insufficiency, though certainly people are at risk for temporary adrenal insufficiency with some of these medications. The cons is chronic disease management and monitoring burden, because many of these medications need testing and monitoring and considering side effects. Also in the United States, obviously the cost is a consideration and what happens with change of insurances and so on and so on. So just one slide on, in general, medical therapy in United States, Europe, and kind of what is approved for Cushing syndrome. Steroidogenesis inhibitors include ketoconazole, osilodrostat, miterapon, mitotane, levoketoconazole, and etomidate. Obviously, not all of these are appropriate in outpatient setting or at all. For example, mitotane, I think, is very rarely appropriate for Cushing's. We have glucocorticoid receptor blockers, currently mifepristone. And I just want to point out that not all of these medications are approved for Cushing syndrome in the United States. Some are approved in Europe. So what are the factors to consider when choosing steroidogenesis inhibitors? Well, all of these are the factors: ease of use, rapidity of action. For example, in someone with very severe hypercortisolism, I would want something that works very quickly. Degree of probable biochemical normalization, there is more and less potent drugs. Tolerability, specific clinical improvement that we are looking for, local availability and cost. Now, in practice, I feel that cost and insurance approval are my major two concerns, because sometimes, especially in people who need treatment right away and cannot wait, that's not necessarily the case here, though. So she decided on medical management. To quote her, she said, "Let me try that for a while I'm making my mind." This was her sort of like say, "Let me try that for a year and then I'll decide what to do." And after discussing several options and checking with her insurance company, she called me. "I have osilodrostat in my hand." So at that time, we started osilodrostat 2 milligrams twice daily. Her 24-hour urine cortisol decreased from 46 to 17 microns per 24 hours. Her morning cortisol during follow-up was low. Our normal range goes from 7 to 20, and ACTH became above normal ranges at 71 picograms per milliliter. Our reference range goes from 6 to 60. And she reported fatigue, arthralgias, and myalgias at that time. So the question here, what is it? Are these symptoms of fatigues, myalgias, and arthralgias because of glucocorticoid withdrawal syndrome? Meaning something that happens whenever we experience a decline in cortisol exposure. I actually see it a lot in people with glucocorticoid-induced adrenal insufficiency. For example, someone on 20 milligrams of prednisone for a year, ready to taper down, sort of goes to 10 milligrams and then tries to go to 5 and totally crashes, despite the fact that they're still on supraphysiologic glucocorticoid replacement. Or is it adrenal insufficiency? Cortisol is a bit low, ACTH is above normal ranges in someone with history of ACTH-independent hypercortisolism. Now pituitary gland recovered, maybe in response to low cortisol. So sometimes it's difficult to distinguish, and sometimes a person has both. In her case, I think it is both. I think she does meet the criteria for adrenal insufficiency. She has low cortisol. She also has, in her case, it's primary adrenal insufficiency because of cortisol blockade by osilodrostat. And I think it's mild adrenal insufficiency, but it is there. But I also think she has glucocorticoid withdrawal because it was significant decline in her cortisol. Now, what predicts severity of glucocorticoid withdrawal? We found that there's only one thing that predicts it before treatment, and that's clinical severity score. Remember that points that we assigned for comorbidities and the physical exam features? Apparently, it's really predictive of how bad glucocorticoid withdrawal will be. So this is why I now use it in my clinic, because I think it's good to prepare for that. Not much can be done for glucocorticoid withdrawal. Now, a bit more on glucocorticoid withdrawal, because it's such an important thing, especially with medical therapy. I would like to first highlight what are the symptoms of glucocorticoid withdrawal. And the most common ones are fatigue, myalgias, arthralgias, and weakness. And when I counsel my patients before surgery or before I start medical therapy on this, 100%, almost 100% of patients tell me, "I already have that, no problem." But what I'm learning that the symptoms feel different if they're due to withdrawal than in comparison to how it feels when you have active Cushing syndrome. It's called the same fatigue, but it's different type of fatigue. It's called the same myalgias and arthralgias, but with withdrawal, it feels like your whole body hurts, while before surgery or before medical treatment, because of active hypercortisolism, it more feels like joint aches here and there. So having not experienced either of these, I'm not able really to characterize it better, but that definitely highlights a gap of how we what we know about glucocorticoid withdrawal. Now, one thing is great. Some of the things improve right away, and that would be sleep, mood, headache, sweating, and brain fog. But again, that fatigue, myalgias, arthralgias, weakness lead to apathy, and people feel terrible because they're tired of feeling terrible, and it's so long. So some of the things that help withdrawal, at least after surgery, would be starting with a higher dose of glucocorticoids and tapering it down slowly to physiologic. I'm showing you two strategies we use at our institution, but really, as long as you follow this principle, you can individualize. And then we published some data showing that meditation helps. Also from what my patients tell me, hot bath, massage, hobbies help. I feel like it helps everything. So maybe we should do some of that too. Now, what studies have reported on osilodrostat, that hypotension, hyponatremia, hyperkalemia, hypoglycemia should be monitored for. Our patient actually did not develop any of these, but also in the studies you would see some of the symptoms of withdrawal versus adrenal insufficiency reported with high prevalence that unfortunately they did not do very well as far as distinguishing, is it really adrenal insufficiency or is it withdrawal? But we can assume it's probably a combination of both. So to summarize the situation, Maria has some biochemical proof of primary adrenal insufficiency because of osilodrostat and a combination of glucocorticoid withdrawal syndrome. And she's on osilodrostat 2 milligrams twice a day. Her urine cortisol improved, now it's 17, but again, her cortisol is a bit low in the morning and she feels awful. What would be your approach to monitor osilodrostat therapy in Maria? Would you titrate based on the morning cortisol? Would you titrate based on late night salivary cortisol? Would you titrate based on urine cortisol? Would you just go ahead with block and replace approach? Let's not titrate. Let's just sort of block cortisol completely and give her physiological glucocorticoid treatment. Or do you have any other ideas? So I think actually there is no right or wrong answer here. Obviously, as I've shown you, for her, we started monitoring with morning cortisol, and this is how we found out she may be on too much osilodrostat. If I would just have gone by urine cortisol, I would have missed adrenal insufficiency in her. So I think despite the fact that FDA and all the clinical trials were done based on urine cortisol, in clinical practice, I think it misses this important part of adrenal insufficiency monitoring. I do think that monitoring with late-night salivary cortisol is important, but probably not right away. First, you make sure you don't cause adrenal insufficiency, and then you try to suppress cortisol at night. Block and replace approach is great, but I think in someone with milder types of hypercortisolism, it sort of defeats the purpose of avoiding primary adrenal insufficiency. Nevertheless, I do think it's the easiest for both patients and physicians because we know exactly what's happening. We're not wondering, is there adrenal insufficiency or is there a withdrawal? We know what it is. So I certainly use it a lot in my patients with severe hypercortisolism. So in this case, as I've mentioned, the findings suggested true adrenal insufficiency in addition to glucocorticoid withdrawal. Why? Low morning cortisol, elevated ACTH, persistent symptoms. So we decided to discontinue morning osilodrostat and continue only with evening osilodrostat, specifically at 6 p.m. And we decided to increase the evening dose from 2 to 3. So overall, total daily dose decreased from 4 to 3, but we moved it all in the afternoon. Why? Because we were trying to avoid that cortisol lowering in the morning. Okay, well now I'm hoping to chat a little bit about this. So when initiating a steroidogenesis inhibitor such as osilodrostat, what clinical and biochemical markers would you use to guide treatment titration?
Well, I think this is a very excellent question, and I'm sure every table here could probably come up with a different answer. I think the question is, really, what are we treating? I think we can all agree, because we've all read the studies, that the 24-hour urine-free cortisol was the surrogate marker that has been used in multiple clinical trials to obtain FDA approval for these medications. So of course we default to that, and I agree. Urine-free cortisol is great, it's fantastic, it's a great surrogate marker of cortisol, but urine-free cortisol is not actually the disease. Neither is some of the other things that we check. And I know that we as endocrinologists, right, we love to get labs that are perfect. I do not like to go into my in-basket and see things highlighted in red and yellow and whatever color your EMR uses. I want all my labs to be green. The problem is that the biochemical evaluation sometimes is completely normal and the patient still feels terrible because the biochemistry, the value, the lab value is not the disease. So then I think we have to remind ourselves that the disease and the goal is actually not just normalization of cortisol levels, but actually removal or normalizing the cortisol physiology that is causing these symptoms, like disrupted sleep and the abdominal obesity, the hemoglobin A1C, the dyslipidemia, the osteoporosis, the increased cardiovascular risk. I think these are the things that are the actual clinical things that we are trying to treat here and not necessarily to the labs. So I think I said a lot and I haven't actually answered your question. But I think that is really probably an accurate idea of what a lot of us believe. The urine-free cortisol and the labs, they are a tool, but they're not actually the end point in this.
You know what I would be looking forward to is whenever we have an actually accurate cortisol monitor for 24 hours. Because I think looking at exactly the cortisol curve and achieving that late night cortisol in the normal range and not causing adrenaline insufficiency during the morning would allow this more careful titration of these medications. It's the future.
Maybe like a CCM, like how they have CGM.
I'm looking 10 years in the future.
Yeah, we want our own. We want a continuous cortisol monitor.
Not
Why
just
should
for this
diabetes
purpose.
have it?
Yes. I don't think it's everything, but for this particular reason, I think it would be quite useful. But until then, we can use a combination of late-night salivary cortisol or cortisone and morning cortisol and maybe even time point salivary collections, right? Yeah. Thank you for that.
10-point salivary cortisol sounds like a lot more results in my in-basket.
That's true. That's a down. Well, let's talk about chronotherapy, because this is what we've done for this patient. We decided to do chronotherapy. We decided to suppress her cortisol only part of the day so we don't cause adrenaline insufficiency during the morning. And there's actually one study which did convert people from BID dosing of osilodrostat to only once daily, 7 p.m. in that study of osilodrostat. They did not change the total daily dose. They just switched it all in the evening. And what you see on the right is the salivary cortisol day curve. You see my wish list. So, and they actually documented with a salivary cortisol curve that by switching this osilodrostat to chronotherapy, they were able to suppress cortisol at night in a more physiological way without lowering cortisol in the morning. It was a small study, only 16 patients, and they were very well controlled, on twice a day osilodrostat study. So I feel like we need much more data than that, but it's quite promising. Interestingly also, these patients improved their sleep, which is logical to me because if we improve cortisol overnight, you sleep better. Okay. And that was my case. Now it's your turn.
All right. So now we move on to the most important gland in the body, which is the pituitary gland. This is where I live. So we'll talk a little bit about some of the challenges in Cushing syndrome management. I think we've all covered this quite a bit tonight, that endogenous Cushing syndrome is associated with substantial morbidity and mortality. Persistent hypercortisolism contributes to accelerated cardiovascular disease, metabolic dysfunction, osteoporosis, and neurocognitive impairment. I work at the Cleveland Clinic and have for the last 18 years. So anything that affects the heart is usually goes right to the top of the list of priorities of things that need to be addressed. And, I think in my prior answer, I kind of talked about the misplaced focus here, how we really have this increasing focus on individualized disease modification, and rather than just how the urine-free cortisol looks. So we have this, 4 quadrants here, and the questions I'd like to pose to all of us, which are areas of persistent debate and still open to a lot of discussion, is this biochemical normalization alone sufficient? And what is the optimal therapeutic endpoint? Is it the labs? Is it the metabolic parameters? Is it the Cushing severity score, as Dr. Bankos had talked about in some earlier slides? Should we be aiming for some mild hypercortisolism to avoid adrenal insufficiency? Or, should we keep in mind that there's cyclicity and discordant biomarkers that will influence titration? I think sometimes we get a normal urine-free cortisol, but the late-night salivary cortisol is still abnormal. And how important is it to achieve that, restore that circadian rhythm, as Dr. Bankos had talked about at the end of that case? So I'll talk about one of my patients. Sarah is a 58-year-old woman with progressive metabolic complications and clinical hypercortisolism. She came into our clinic with symptoms of weight gain, fatigue, easy bruising, proximal muscle weakness, sleep disturbance, mood changes, all the typical things. Comorbidities are hypertension, type 2 diabetes, dyslipidemia, osteopenia. And on physical exam, she has the central obesity, the facial plethora, supraclavicular fullness, and this thin skin with ecchymoses. So classic kind of clinical presentation here that led me to order these different tests. So she had an elevated 24-hour urine-free cortisol of 286 microgram per 24-hour. So not borderline elevated at all, it's significantly so. Late-night salivary cortisol was 0.42. The second one was 0.37. Normal would have been less than 0.09. And there was a 1 milligram dexamethasone suppression test with a non-suppressed cortisol of 5.2. Normal, as you all know, should be less than 1.8. And the ACTH here is detectable, right? This is in the normal range. And we know in endocrine, I think we all love to use this is inappropriately normal. So this here is, that ACTH-driven or ACTH-independent hypercortisolism, which, usually directs me to my favorite gland, which is right here. And I don't think I can point. But I think you all can see here that in the left side of the pituitary gland, there's this small rounded area of hypoattenuation. And there it is. It's about 4 millimeters to 5 millimeter pituitary lesion, consistent with the microadenoma. So maybe someone might want to shout out to me, what do you think this means? We have 3 out of 3 tests positive for hypercortisolism. I see a lesion here on my MRI. What should I do next? IPSS. All right, let's see. So the mild, in this patient, that was very clear, but some patients may present with milder ACTH-dependent hypercortisolism with some variable lab tests. Sometimes we can have that discordance between the UFC and the late-night salivary cortisol. And then MRI lesions that are less than 6 millimeters might represent incidentalomas. So I think, in this case, I have to agree with my colleague here, who said that the next step is IPSS. In fact, some of my research at Cleveland Clinic in 2015 had showed that if you have these tests being positive and the lesion is larger than 6 millimeters, then you do not have to do IPSS. But if it's less than 6 millimeters, then the next step is IPSS. So that is what I would recommend to this patient. She had, of course, these clinical concerns, the cardiometabolic disease, the bone health, the reduced quality of life, and I am concerned here for long-term cardiovascular risk. So I am a pituitary endocrinologist. I work actually in a neuro-oncology center. I think Dr. Bankos was showing us bilateral adrenal adenomas. I have a clinic with bilateral neurosurgeons. I know when I sit in clinic on either side of me that I have these 2 neurosurgeons, and the first line therapy for pituitary ACTH-dependent hypercortisolism remains surgery. In this patient, some patients now, they have this choice, and some of them are prioritizing different things. For some reason, they don't want to have surgery. They don't want to go through IPSS. That sounds, scary to them. They want their metabolic disease, they want their chronic disease managed. And, when I started practicing, we didn't have any medications approved, FDA approved for hypercortisolism. And now we have 3 in the US and more in Europe. So we are able now to offer patients medical options, and that's a possibility. And we have the options here for some precision titration, which might reduce morbidity and minimize the adrenal insufficiency risk. So I selected this case to present because this patient flat out refused, or I think she declined, to proceed with IPSS or surgery. And this is after multidisciplinary counseling. Like I said, I work with neurosurgeons. We go into the room together to talk to patients. And both of us spoke to the patient. We presented her case multiple times at our multidisciplinary pituitary tumor board, and still she declined to do that. So back to this question, what is the primary long-term treatment goal? Is it urine-free cortisol normalization alone? Is it symptom improvement only? Is it reduction in cardiovascular and metabolic morbidity? Is there tumor control only? Is it avoid adrenal insufficiency at all costs? That is surprising, and I think it's also accurate. So this is one of those questions where you don't really have a correct answer, but it's probably best to eliminate everything that says only. And I agree, I think, with the group that in this situation where a patient has declined for the evaluation and surgery, that we need to move on to controlling the hypercortisolism as much as possible, yes, but the main idea here is to reduce cardiovascular and metabolic morbidity. And I think at least one of my colleagues here on stage will be happy to hear that. Decide which one. All right, so let's talk a bit about, sorry, my apologies.
Doing nothing on the symptoms. You can put them on a statin, an ACE inhibitor, and you can put them on GLP-1, but the symptoms of hypercortisolemia still exist.
Yes.
It's treating secondary parameters.
Yeah. So I think our approach, and it might be the same at your center, is that we actually do give medications to control the cortisol. And we do follow, we are aiming to normalize the urine-free cortisol. And I tend to get a serum cortisol on the same morning that they return their urine-free cortisol, so that we can correlate those two values and then continue to follow the serum cortisol, so that you're not asking someone to check a urine-free cortisol every 2 weeks. Most patients don't like that. So please understand that we are checking the cortisol, we are treating the cortisol levels, but we are also monitoring the improvement in high cholesterol, hemoglobin A1C, and blood sugars that happens from treating the cortisol. These cardiovascular and these metabolic parameters are improving. So it's not that we're just giving a statin or an antihyperglycemic and ignoring the cortisol.
All respect to you, forgive you please. The way it was answered, if people naive, they think, no, you control cardiovascular factors to please the cardiologist. We need to control the main issue beyond, which is bringing the cardiologist.
Thank you so much for that. I think we could definitely have worded the question better. We are not independently treating the cardiovascular risk factors and mutually excluding the cortisol. The cortisol is being treated, and we are following the cardiovascular risk factors.
Thank you.
All right, so then let's go on to these medical options that we now have, which we did not have 20 years ago. So we have ketoconazole. This inhibits the 17-alpha hydroxylase and 11-beta hydroxylase. I think we know that this requires gastric acid for absorption, It acts quite rapidly. You can have urine-free cortisol normalization in 50% to 60%. Safety profile has been a concern for a lot of us in the past. You can have the hepatotoxicity or an increase in liver enzymes, GI disturbance, drug-drug interactions via the CYP3A4 inhibition, adrenal insufficiency, skin rash, gynecomastia in males. So when do you consider ketoconazole? If there's mild to moderate hypercortisolism, combination therapy, and sometimes women with hyperandrogenism, this might be a good choice. But I think because of the hepatotoxicity, definitely not my first choice. Levoketoconazole is an enantiomer of the racemic ketoconazole. It is FDA approved. Potentially, there's a lower hepatotoxicity risk and an improved side effect profile. Urine-free cortisol normalization in 30 to 50%, and then improvements in cardiovascular and metabolic parameters. So here we have a graph that shows the mean urine-free cortisol concentration here on the vertical axis, and you can see how that drops, and it remains sustained from months 1 to 6 of treatment. So there's very rapid normalization and then sustaining that effect. The safety profile, the most common adverse events are nausea, headache, hypokalemia. You have adverse events of special interest. I think we have to mention the liver enzyme elevation, QT prolongation, and the adrenal insufficiency. This is pretty similar indications to the prior ketoconazole, mild to moderate hypercortisolism, acne and hirsutism in women, and you want to avoid this in men due to the hypogonadism. Then we come to osilodrostat. This one can cause potent CYP11B1 inhibition. You can get rapid cortisol suppression. It's very effective. High urine-free cortisol normalization rates and flexible titration. And then you have the potential chronotherapy applications as Dr. Bancos utilized in the former case with her patient with that nighttime dosing. With the safety profile, you can see here, if you look at this, the bar graph here, these are the patients with hypercortisolism-related adverse effects. And we have the LINK-3 and the LINK-4 study. And in the LINK-3 study, about 30.7 patients developed some adverse event baseline to week 12. And then after that, in the lighter color on top, that's after week 12, you have 20%. And you can see that in LINK-4, there was a significant decrease, and I think a lot of this is because the studies are designed differently, of course, but what happened as time went on, we became a little bit more cautious in how much we escalated this, and I think we got more experience with how to utilize this. Our monitoring got better, and hence the adverse events, which most of the times were related to the effectiveness of the drug and the rapid normalization of cortisol, and that is what we see here. Osilodrostat is used in patients with moderate to severe hypercortisolism. Some of us use a block and replace strategy. You have a very wide dose range, and hyperandrogenism is not a major concern. Metyrapone, I don't use this very often. I think now that we have other options, a lot of us default to that, but this is a medication that has been used. It inhibits 11-beta hydroxylase and blocks cortisol synthesis. Also rapid onset of action. Urine-free cortisol normalization is 47 to 75%. Safety profile, we have the GI upset. You can have accumulation of androgenic and mineralocorticoid precursors, hirsutism, acne, hypokalemia, edema, hypertension, fatigue, and adrenal insufficiency. So this is a good option if you're considering you need very rapid onset of action or some pre-op bridging therapy. Has been used in pregnancy, and there's also a wide dose range here. And then we have mifepristone, a glucocorticoid receptor antagonist. This one also antagonizes the progesterone receptor. In long-term use, it can cause endometrial thickening, short-term thinning, improves hyperglycemia, improves clinical symptoms. The key evidence for this, comes from using the studies with Cushing syndrome and type 2 diabetes or hypertension, where 60% had a more than 25% improvement in glucose area under curve. So I always tell the story that I have prescribed mifepristone, and I got a call back from the pharmacist And they called to educate me that I could use a cheaper drug to treat diabetes. And I think that I know some of my colleagues have received calls like that because this drug actually causes a good improvement in hemoglobin A1C. Back to that, we're treating cortisol, right? But we're improving the diabetes, and that's what initiated that phone call from the pharmacist. I think they suggested that I use metformin because it was a lot more cheaper, I think, and I had to explain to them what I was doing. Here you have the plasma glucose on this graph, and you can see the oral glucose tolerance test. And you can see at baseline is the top curve, and that remains high. Patients being treated with mifepristone, the red graph is week 6, and then the two bottom graphs, the green and purple, is week 16 and week 24. So you can see how with this use, the hemoglobin A1C, this is the glucose parameter, it improved significantly. And that's why mifepristone is approved for hypoglycemia in Cushing syndrome. It's a little bit harder to monitor. Of course, you can't monitor the cortisol levels. It's going to be high. You monitor the clinical response, glucose control, weight, edema, blood pressure, and other comorbidities. And then in the Catalyst study, Catalyst Part 2 study, which was a randomized placebo-controlled study in patients with inadequately controlled type 2 diabetes and hypercortisolism, the primary endpoint was the change in hemoglobin A1C from baseline to week 25. And this is where you can see that, excuse me, in the patients being treated with mifepristone, there was an improvement in A1C of 1.47%. And I think, we're, of course, at this meeting, so pretty fresh in our minds is the improvement that patients get from GLP-1 agonists. That's sometimes 2% or more if you're lucky. With some of the other drugs, the older things like metformin, you'd get, 1 to 2% drop. So seeing that this mifepristone can cause this drop is this is why the drug was approved in this way. So when do you consider mifepristone in patients who have hyperglycemia, and if the doctor and the patient are okay with following symptoms and everyone's comfortable with not monitoring cortisol levels, which can be challenging? So just to summarize here, we've talked about the therapeutic classes, so steroidogenous inhibitors, pituitary-directed therapies. We haven't gone too deeply into that, but that's pasireotide, glucocorticoid receptor antagonist. And then the mechanistic considerations are, which one of these is going to rapid biochemical control, which acts at the tumor, which of these can be adjusted for chronotherapy or circadian cortisol restoration, ACTH escape, and monitoring complexity. So what is the most appropriate next step for Sarah? Observation, repeat testing, start steroidogenous inhibitor therapy, radiation therapy, or rediscuss surgery. You can enter your options. Yeah. So, all right, so I think, again, we're moving more and more towards medical treatment. So I will say that at every point in my discussion with this patient, when she comes in, I do go through all the options, and surgical, it's always discussed, right? That is the standard care. I tell her this is the standard care. This is the first line therapy. This is the option for potential benefit, definitive management. And in her case, after all of this, the answer was to start steroidogenesis inhibitor therapy. So I had to choose from the options that we discussed in the aforementioned slides, and we ended up choosing, so we did acylodrostat, 2 milligram twice daily, titrated every 1 to 2 weeks, and I monitored all of these things: urine-free cortisol, electrolytes, ACTH, as well as the clinical symptoms. by the 6 weeks follow-up, her urine-free cortisol had nearly normalized. I think it went from over 200 to like 60. She had improved blood pressure, and I did not do any antihypertensive medications. She had improved hemoglobin A1C. She had better sleep and energy. So we targeted the cortisol, but we had overall improvement in some symptoms as well as some metabolic parameters. So questions that we ask is, which biomarker should drive titration if someone has persistent fatigue despite normalized urine-free cortisol? And I am definitely kind of a by-the-book person. I like to see that the urine-free cortisol has normalized as well as the cardiovascular parameters. And sometimes patients still have fatigue. And sometimes we have discordant biomarkers. And sometimes, even with the normalization of the UFC, the late-night salivary cortisols are still elevated, and that might be what is contributing to their disrupted sleep and energy and things like that. So the long-term goals are, to reduce cardiovascular morbidity, improve the metabolic outcomes, improve quality of life, reduce thromboembolic risk, and preserve bone health. If you recall, this patient is 58, postmenopausal, and had osteopenia, so I'm trying to deal with that as well. Long-term management requires longitudinal endocrine follow-up, multidisciplinary cardiometabolic care and biochemical monitoring, shared decision-making, and personalized treatment. And, just to sort of address some of the questions that might be going in your minds, I do refer this patient to bone endocrine calcium clinic to address the osteopenia. I do refer this person to our preventative cardiometabolic risk clinic. I continue to treat the cortisol, but I know that I have to treat these patients holistically and with the support of a multidisciplinary team. I think in Cushing's, with every system that can be affected, it's very important to be able to have that support from your colleagues in different specialties. Because our goal is, once again, not to make the urine-free cortisol. I can do that, but I also want to make sure that I've improved the rest of their quality of life. So key takeaway for endocrinologists here in the room is that we have more options now, and we have medications that can cause us to control cortisol and normalize the cortisol. But our management has to extend beyond just making the labs look good. Steroidogenesis inhibitor therapy is a potent cortisol suppression. We just have to make sure that we're interpreting the tests correctly and in the context of this individual clinical case. And then I think what Dr. Bankos talked about, that table where she had the features of glucocorticoid withdrawal syndrome and adrenal insufficiency, I think that is very critical in monitoring these patients. So I'll hand it back to Dr. Butler.
Great. Well, thank you very much for those two really erudite and nuanced cases and the discussion. So let me take a few minutes and talk about interdisciplinary care, and then also how the cardiology community is thinking about it and getting involved in this. My one request, again, I have several questions that have come up during the presentations, but please do put in your questions because we would love to have a discussion with you. We also have a virtual audience, so when you speak out a question, they don't understand or they listen, so it's difficult for them to follow up. So would request if you can just type in your questions and then I will read it and we will have a discussion related to those questions. So it's plenty obvious from these discussions that there are multiple specialties that are involved in this case. In these sort of cases, with endocrinologists sort of being the orchestra sort of conductor in the middle, they have to make all the decisions, but then also go and reach out to their respective colleagues depending on the scenarios. And these are complex decisions, whether these are surgeons related to treatment of adrenal glands or neurosurgeon, radiologists, neuroradiologists. All of these specialties are involved in the management of these patients. Specialty programs, nurses and nurse practitioners and clinical pharmacists play a significant role. And many of these patients with multimorbidity or related mood-related disorders related to cortisol and involvement of psychiatrists or mental health specialists may be involved as well. Pathologists for the diagnoses, nutritionists for management of their weight and nutritional concerns and obviously comorbidities. And finally, teaming up with their primary care physicians can help management, interprofessional team management as well. And these are sort of the domains of the kind of things that the roles and responsibilities are needed for interprofessional team. The accurate diagnosis, and it's not only the diagnosis, but the localization, appropriate treatment selection, whether it is surveillance, whether it is surgical treatment, medical treatment, and if medical treatment, which medications to use and how to follow up these patients or radiation treatment. Long-term follow-up, as we saw from the first case as well, that some of the treatment and some of the results may be time-limited and things may change over time, so long-term follow-up is important. We are all sort of coaches. The patients are the players, and for better adherence, compliance, long-term management, patient education becomes critically important as well. And at the end of the day, it's not only mortality, morbidity, the way we think about it from a clinical lens, but also improvement in patients' quality of life and symptoms as well, which becomes important. So with that said, let me now turn to why cardiology is involved in cardiology. So thinking about it, so when I was asked to participate in this program and the announcement was made, two of my very dear friends who are endocrinologists, one in Jackson, Mississippi, and one in New York, these were the two text messages I received from them. One of them said that I waited all my life to learn about cortisol from a cardiologist. And the other said, trying my best to get to the conference, I'm hoping you can fill in all of the blanks of the many unresolved adrenal questions that I've had over the past almost 4 decades as an endocrinologist. Finally, I will get all my answers. So these were the two text messages I received. So why a cardiologist? Well, so a couple of things. All of you may have heard this whole CKM syndrome, cardio-kidney metabolic syndrome, and cardiologists are really thinking about this quite a lot. And where we are right now is that, I grew up sort of an era where specialization was not enough. It was sub-specialization, and we were sort of really converging. So you do internal medicine, and then you do cardiology, and then you do heart failure transplant, and then, even then you get pulmonary hypertension and congenital heart disease and transplant and VAD and all that kind of stuff. But what we are really realizing that the pathophysiology of many of these diseases are actually the same, and these are underlying things like inflammation and oxidative stress and endothelial dysfunction and insulin resistance and adiposity. And these things drive development of the disease if you don't have the disease, and these are the same pathophysiologic parameters that lead to progression of the disease if you do have the disease. And these pathophysiologic parameters are commonly shared across multiple disease systems, including the heart and the kidneys, where we have most of the data, obviously diabetes, and more data are coming out with liver as well. So we are already sort of moving from CKM syndrome or cardio-kidney metabolic syndrome to CKLM syndrome. So there's a lot that you will hear continuing in that direction. Actually, the American Heart Association just last week came out with their first CKM guidelines as well. Now, there are a couple of bad news in there and a couple of good news as well. So one bad news is that a person may come to me with one disease and go to nephrology with one disease or endocrinology with one disease, but we can be pretty certain that the other disease process has subclinically already started because it's the same common pathophysiology. And then two, they tend to multiply each other's prognosis. So if you have one disease, you have bad prognosis, but if you have multiple of these diseases, which over time they will develop, the prognosis gets particularly worse. So what is the good news? The good news is that if you have effective therapy that can modulate this underlying pathophysiology, then not only do you improve the patient's outcome, it's the same therapy you give for prevention of disease. And if you catch the patient later when they have the disease, the same therapy leads to improved outcomes if you have the disease. And while you may give the therapy for one disease or another, you have multiple organ systems that get benefit at the same time. Now, bringing this to this particular session is that there's a lot of data related to cortisol and blood pressure related issues and blood pressure control, and also a lot of the data with diabetes control and glucose control and the role of cortisol. We have learned a lot about this from aldosterone. So when we think about aldosterone, we have 50 years worth of data that aldosterone is associated with relation with this cardiokidney metabolic syndrome. And we have been using MRAs in patients with heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, chronic kidney disease, and there are data for benefit in patients with diabetes as well. But we are not looking for Conn's syndrome. We are not looking for primary hyperaldosteronism. Just the range of aldosterone leads to associated worsening prognosis, and MRA use irrespective are associated with improvement in outcome for these patients. However, because aldosterone levels are associated with worse outcomes, and with MRA therapy, there is actually an increase in the aldosterone levels. We are now also getting more and more convinced, although the data are not out there exactly so far, and that is that there are MR-mediated and MR-independent effects of aldosterone. So theoretically speaking, when you block an MR receptor and the aldosterone levels go up, the MR, non-MR mediated effects can worsen, and then also the high MR aldosterone level may displace spironolactone from the receptor as well. So there's a lot of interest in developing aldosterone synthase inhibitors. With aldosterone synthase inhibitor, we obviously now have a first approval for resistant hypertension, but right now there are aldosterone synthase inhibitor trials going on in patients with heart failure and reduced ejection fraction, heart failure with preserved ejection fraction, chronic kidney disease related to diabetes, chronic kidney disease related to non-diabetes, and two very large trials. We're talking about 11,000 patient trials in high-risk patients for prevention of heart failure as well. If those trials are positive, then the issue comes up. One, what is shown right here in the slide. So the idea here being that with MRA, you only block the MR receptor, but what about the aldosterone non-MR mediated effect, and that with ASI, both will be affected and you will have further clinical benefit. The problem is that we think right now, this whole field has been delayed by almost a decade because the earlier forms of aldosterone synthase inhibitor were relatively non-specific and cortisol levels were going down. And very specific aldosterone synthase inhibitor like vicadrostat and baxdrostat have been developed that are being tested in these studies. However, as you know, that there is inter-individual variability. Yes, on average, there is not a whole lot of cortisol lowering with these drugs. There will definitely be individual variation. So just like the cardiologists over the past 5 years have learned a lot about glucose management, diabetic ketoacidosis, euglycemic diabetic ketoacidosis, genital myocardic infection with the use of SGLT2 inhibitor, if these 5-6 trials are positive, the cardiologists will really need to learn about cortisol more and watch out for cortisol insufficiency and management of cortisol insufficiency in these patients. However, there is another really interesting question that is coming up. And that question is that Mother Nature has these sort of, again, I'm a little bit shy talking to a group of endocrinologists about beta HSD1 and beta HSD2 and cortisone and cortisol conversion. But the bottom line is that affect primarily first of all, cortisol levels are much higher in the body than aldosterone level. And the MR receptor affinity for cortisol is much higher than aldosterone as well. And most of the organ systems, barring, say, kidneys or salivary glands or colon, most of the places in the body, it's the cortisol which is acting on the MR receptor and on the heart. So one of the hypotheses which is coming up is that when you give mineralocorticoid receptor antagonists and you get all the benefit is because you're blocking both the cortisol and the aldosterone effect in that. And if you don't give an MRA, and if you get very selective aldosterone synthase inhibitor, you leave the cortisol effect on the heart unattended. And that maybe it's the non-selective blockers that block both cortisol and aldosterone are probably the better drug for cardiovascular risk management. So again, this is way early. You were talking about, 10 years ahead and continuous cortisol management. We are probably 15 years ahead here. But I just want to give you a little bit of a flavor that in the near future, if the ASI trials are positive, then for the management of cortisol and cortisol insufficiency in some patients, cardiologists will need to get involved more. And then the last thing that I will mention, and that is this issue of MAX. And very much like aldosterone, I know that the data for MAX are developing, but all of this, there are data that would suggest, and my colleague can correct me, that difficult to control glucose and uncontrolled or resistant hypertension, a third to a fourth of the patients actually have high cortisol levels. So this issue of MAX and whether that will need to be treated for cardiovascular risk reduction. So I think we are just at the precipice of learning all of this, and we have some really interesting times ahead of us. And I will represent the cardiology community at large, and we look forward to working with the endocrinology community to answer all of these questions. So with that said, we will move on to our question and answer session. A few concluding take-home message. Medical therapy is the cornerstone of management for many of the patients with Cushing syndrome, particularly post-surgery. Titration of steroidogenesis inhibitors is a dynamic process requiring frequent monitoring to balance efficacy and safety and coordinate the care with primary care team to aggressively manage the cardiovascular and metabolic comorbidities associated with these disorders. So now I have the easiest task in the world because there is not a single person in the room who expects me to answer any of the questions. I'm sort of the traffic cop that gets the questions and forwards it to my colleagues. Okay, so first question. Is there any way to distinguish GWS from AI in patients with mifepristone? How concerning is this when choosing a therapy?
In my opinion, it's very difficult to distinguish glucocorticoid withdrawal from adrenal insufficiency while on glucocorticoid receptor antagonists. That's all I can say. There is no biomarker. I guess what helps is to have a bit of clinical judgment and have a feel.
Yeah, I agree. And I think that it's definitely one of the deterrents when I have to choose medications. I prefer to choose something that I can monitor. Clinical features, of course, that's all we have with mifepristone. The cortisol is of absolutely no value, and patients have to really know themselves well. They really need to know their symptoms, and you have to be ready to step in there and give them, some rescue steroids in case they need that. So we don't have an answer to that, except clinical features is the only thing you can monitor on someone on mifepristone.
Got it. So two relatively crispier question. What is your cutoff point for ACTH value to differentiate ACTH dependent and independent? 15 or 20 or something else?
Yeah, so 20 most of the times, although I have looked at all of the cases, and it's a couple hundred, and we have had a few pathology-confirmed ACTH-dependent pituitary where the ACTH level was between 15 and 20. So I think most centers, if they look at all of their cases, pathology-confirmed Cushing's, that you may still find a couple of cases where the ACTH levels are around 15 and not quite as high as you would expect it to be.
So I have a bit of a long answer, but I'll go quick. So because I'm also an adrenal endocrinologist, I'm adrenal and pituitary endocrinologist, although in pituitary I mainly see people with Cushing's. I certainly have seen a fair number of people with MAX, mild autonomous cortisol secretion, and even some people with adrenal Cushing's with ACTH higher than 20. Majority would have ACTH under 20, but there are several absolutely confirmed autonomous cortisol secretion with ACTH higher than that. On the other hand, I also have a dozen of patients with confirmed pituitary Cushing's with ACTH below 20. My personal lowest was 13, though I have seen Dr. Finling's poster, and it was 9. for one of his patients with pituitary Cushing, so I guess it is possibly even lower than that. So actually, there is some exciting emerging data, not yet published, that we've presented as an oral presentation, what to do in those cases, in case you're interested. If you have people with hypercortisolism and ACTH between 10 and 40, you can do post 1 milligram dexamethasone ACTH, and a cutoff of 8 after dexamethasone distinguishes between adrenal and pituitary with 99% accuracy. So there's some other information on 1 and 8 milligram dexamethasone suppression test, but I'll stop here. Yeah.
What is a good level of dexamethasone with DST when you consider, and when do you consider higher than 1 milligram DST?
So I think it depends on your lab. At the Cleveland Clinic, the value for low dose is that the dexamethasone level has to be more than 140. And then for high dose, there's a different range. It's usually more than 4. I can't even remember. It's in the hundreds. Most of the times with high dose, you'll end up in the thousands. But I think this question here is specifically about a low dose. So if you don't get a level of more than 140, and this is why it is so critical to make sure that the dexamethasone level is measured on the morning when patients come to collect their post-suppression cortisol. A lot of times I get referrals from outside, and that has not been done. And you cannot interpret a low-dose DST without a dexamethasone level. So if I see that the level was not more than 140, sometimes it's 105, sometimes it's 80, sometimes it's 90. I know they took the pill, obviously, they shouldn't have dexamethasone there, but the dexamethasone level didn't go up. Then I might consider either a 2-day low dose, or if it was just borderline low, I would move to just doing a 2 milligram dex suppression test. But I think, the answer to this question isn't like what dose of dexamethasone you should give, but what should the level be the next morning? And in our lab, it should be more than 140.
So I guess I would add just a little bit to that. Most of the people would have dexamethasone levels between 200s and 500s after 1 milligram dexamethasone. I should also say if your cortisol after 1 milligram dexamethasone suppression that is below 1.8, you don't care about dexamethasone levels. I have had people who normalize their cortisol after dexamethasone with suboptimal dexamethasone levels. Mm-hmm. So it's really more if it's abnormal. And I think the final thing is there's always a percent of people, whether we use 100, some people use 140, other people 180, there is a 200 based on the assay. Really, you do get a few people who have false positive results with any of these cutoffs. So if you suspect a false positive, increase your dexamethasone. And I would say you could expect double the dexamethasone level if you double the 2 milligrams dexamethasone.
Okay, so some quick responses. Someone on prednisone for prostate cancer hormonal therapy, but has adrenal incidentoloma. Which test is reliable to test for cortisol assessment?
I guess I can take a quick one because I think I see more adrenal incidentalomas. Yes. So first of all, I would ask a philosophical question, why do we care? This person still needs prednisone, right? Would you treat autonomous cortisol production? But if you think you do care and it's important to distinguish, then all you have to do is give the dexamethasone in the evening, measure cortisol with dexamethasone levels before the patient take prednisone the 8 a.m. before. Because remember, prednisone does not, first of all, it's out of the body for 24 hours, and it should not do anything to autonomous cortisol production. You would still measure it. I actually have several people like that in my clinic with abnormal dexamethasone suppression test, but with prednisone-induced glucocorticoid-induced adrenal insufficiency.
Is there a problem if the patient took the dexamethasone pill earlier the previous day rather than the recommended 11 p.m. to midnight?
It's all about dexamethasone levels, I would just say.
Yes, and it's more about also their circadian rhythm, right? Yeah, I think when I trained, it's over a decade ago, we used to tell people, take it at 11 p.m., stay up and take it at 11 p.m. And now we're telling people, take it at what is your natural bedtime. So then it's just what the level is in the morning.
Got it. For MAC, is there a DHEA cutoff that can help with diagnosis, as many patients don't have completely suppressed DHEA or ACTH?
So I think it's for MACs. Is it
Yes.
the question? Well, we did publish a systematic review and meta-analysis showing that the best cutoff for max for DHA sulfate is 60 to 70, but it's really, there's false positives and false negatives. If you want very few, full false negatives, you go for DHA sulfate of 25. If you want very few false negatives, you go for DHA sulfate of 120. You always lose some to gain some. So I actually think we should look at everything in context.
Okay, I haven't seen any other medication apart from osilodorstat being used. How do you counsel patients when starting them on osilodorstat, and what would sway you to use any other medication?
This is a good question. I think the reason that we, in both of our cases, right, and these were real life cases with some identifying information changed, is that I chose osilodorstat because I don't have to worry about the hepatotoxicity and the monitoring that comes if you use ketoconazole off-label or the enantiomer, which is the levoketoconazole. And then also, with mifepristone, we've already, I think, talked about how difficult it is to monitor this, and you have to depend on the patient's symptoms, and you have to decide, how do I deal with the potassium, and when do I decide to jump in there and give rescue steroids, and then also this is probably not the best medication choice in a woman who's in the reproductive age group, as a lot of our patients with Cushing's disease are. So I think this is why this has become, osilodorstat is something that I can give. It is effective, it works quickly, I can monitor it objectively, and that's why it has become that choice. I don't think that the paradigm has shifted completely, at least in the pituitary world, to say that surgery is not the first choice, but I have to say that I am so grateful that in the past 2 decades that I've been in medicine, that I now have many options with which to treat hypercortisolism, and I'm so grateful to be able to practice in this landscape.
So we're right on time. Let me just squeeze one last question in. I won't be able to go through all the questions. There are several others, but after the presentation, we'll be around here for a little ways longer, so you can maybe ask the rest of the questions one-on-one. So this is for you, Dr. Bankos. For the first case, was there a reason medical therapy was not considered after the patient had AVS and diagnosed with bilateral disease prior to growth of the left adrenal nodule?
Yeah, so it's a longer answer, but let me try my best. So in anyone with bilateral hypercortisolism, there is a pretty good chance to actually get in remission for years and sometimes for decades in selected cases with unilateral adrenalectomy, I should say with debulking surgery of any kind. I think it was worth a try. In fact, I think it's worth a try for most people. On the other hand, you have medical therapy that is still extremely expensive and needs a lot of work. So that was the main reason.
Great. Well, thank you very much.
On that patient, you only went by one test. You didn't need confirmatory testing for Cushing's, the first one.
So yeah, our first patient had elevated 24-hour urine cortisol of 46 microns per 24 hours. She had abnormal dexamethasone suppression tests several times and suppressed ACTH. Especially with her history, I would say it was pretty clear she has recurrent hypercortisolism. I guess that's my another thing, let's not over-test our patients.
So now we are really over time, and it's late in the evening. So again, thank you so much to both of our presenters and to all of you for joining us in this session. Please use this QR code to earn the credit as well. And again, thank you so much for this wonderful session and for coming and joining us. Thank you.
Nice work.